Hey Andrew, so as we discussed last week, I chose to do my educational presentation on Cadasil, which stands for Cerebral Autosomal Dominant Arteriopathy with Subcortical Infarcts and Leukoencephalopathy. I chose to do this because you and I had some personal hands-on experience with a patient that was dealing with this, and it kind of piqued my interest, and I wanted to take a little time to learn a little bit more about what was going on with them. So what I found is that this disease typically affects younger individuals, and the onset of strokes can usually occur anywhere between 30 and 66 years of age. It can lead to an inability to walk without assistance between 56 and 64, confinement to bed between 59 and 69, and even death between 61 and 74 years of age. I found that the typical diagnostic procedures to determine whether or not somebody has Cadasil is through an MRI, and this can be detected around the 35. Research shows that patients will generally experience 2 to 5 ischemic events during their lifetime, and this can lead to motor and cognitive decline, gait disturbances, and urinary incontinence. So with our patient, he presented with gait abnormalities, had some difficulty walking early on, and required assistance to avoid obstacles while he was ambulating, and would typically sometimes trip over his own feet, but as he progressed, he got better, and we didn't have to assist him as much. He also kind of had issues with his balance and his proprioception, which we worked on as well. The patient's quality of life is threatened not only by these disabling symptoms, but by strokes, vascular cognitive impairment, and seizures, migraines, and mood disorders. Cognitive decline with these individuals is commonly progressive and worsens as they continue to have more and more strokes. This can involve executive function, processing speed, memory, and attention deficits. We saw firsthand it typically took him a few moments to process more complicated questions. He was easily distracted when we were walking throughout the halls or when he was performing exercises, and we typically had to kind of rein him back in because of the attention deficits. With memory recall, he typically would require some prompting to get some things out of him. This disease is characterized as a small vessel disease, and it can include stroke, vascular cognitive impairment, and dementia as well. So there are 4 main clinical features I found with Cadasil, and these are migraine with aura, subcortical ischemic events, mood disorders, and cognitive impairment. Migraine with aura is reported in 20 to 40% of Cadasil patients and is often the presenting manifestation with Cadasil. Mood disorders are also reported in 20 to 31% of the patients, and this is mainly characterized by severe depression and apathy. This isn't something, as far as mood went, that we were really able to ascertain with him or determine because he was nonverbal. So it was kind of hard to ask him, like, have you been feeling apathetic, or have you been dealing with any severe depression or anything like that. One of the studies that I found suggests that testing should consider sequencing of 11 exons related to the Notch3 gene, the Notch3 gene being what is typically affected in the Cadasil patients. Exons are just parts of the DNA sequence within the gene, and they correspond to the mature part of the RNA as well. Cadasil can be caused by more than 150 mutations in that Notch3 gene that I referenced earlier. And this gene particularly affects vascular smooth muscle cells of the small arteries and parasites of the brain. I also found another study that found that accumulation of what is referred to as the PKR pathway is activated in these individuals, and it is believed that the PKR pathway is related to neuronal apoptosis or cell death within their brain. One of the studies that I found was PT and OT were performed for about 3 months. Due to the disabling and progressive outcome of the disease, these treatments were critical to minimizing its impact on the individual. So for us, we would perform balance. We started off kind of with simple balance. We'd have him just doing static standing, static seated, and then we progressed him to more functional standing and seated balance activities where he was doing multi-directional balance. We had him doing some cones where he would step towards in different directions, towards different colors, so it incorporated a more cognitively demanding aspect to his balance. We worked on his proprioception, kind of walked around obstacle courses, would work on avoiding things in the hallways, as well as just general extremity strengthening as well to bring up those deficits that they had experienced due to the strokes that he had in the past. So this is just some of the information that I found. I hope you enjoyed it. If you have any questions, just let me know.